Hello and welcome to Sensei Podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei Podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, Dr. Alex Napa from Amsterdam, where he's created one of the premier CTO programs in Europe and around the world. Alex, thank you so much for being with us today, and super excited to learn and hear about your story and how you became so good as you are now.
Wow, that's very nice, Manos. But in all honesty, we are here because you learned us.
No, I don't think so.
Well, I
don't
do
think
think
so.
so.
But tell me, how did it start? So obviously, you and Paul, you created an amazing program. But how did it all start? Were you always together from the beginning? Did you start separately? How did it all come along?
Well, yeah, we started I think it's like a decade ago. I think in January 2014, we actually started. And Paul was already an interventionalist, while I was still a fellow, not even a cardiologist. I was in my last year of cardiology. And I was on the CAT lab already. And we had a CTO program in our hospital that was run by a senior dinosaur, so to speak. And he was doing only antegrade procedures. Where the wire is stuck, you film it from 10 positions, you don't move the wire, and that's how they did it, using multiple wires, of course. And then Paul had the idea to kind of get the program energized. So he spoke to Boston and they brought in some proctors. You may know them. It was just Simon Walsh and Colin Hanratty. You know those guys. So they came in at one day in our hospital, and that's how it started. But after that, well, I think a historical day, our senior interventionalist, he pulled out of the program because he said, well, this is not for me, because, Simon and Colin, they were knuckling the hell out of it. And that was not how he thought and how he would like to operate. So he backed out, and then Paul was alone. And I was on the CAT lab, being not even a cardiologist. So I stepped in. So we decided to run it together. The first year I was next to Paul, and then I did my residence or my fellow in interventional cardiology. And when I finished, it was my turn. So then we already had one or 2 years of practice together. And well, that's how it all started. It was an amazing journey.
Mhm. Wonderful. And why did it all start? So obviously, as you know, there's limitations, but at the same time, it was traditional to do it the old way. So what pushed you and Paul to kind of get to do things in the new way of doing things?
Uh, well, I was still blind, so to speak, and Paul was looking for a niche in interventional cardiology. And we are both thrill seekers. So we like some adrenaline. We like to do new stuff because it's energizing in our minds. You have to think out of the box. So all those kind of factors are involved in why we had the energy to do it, because it was just something new within the Netherlands even. There was no real retro program at that time within the boundaries of the Netherlands. So it was something ambitious, like we loved the coronaries from the start. So combining all those things, the momentum in time in CTO worldwide, with all the techniques and devices being brought into the market, it was just something new for us. And in all honesty, we visited CTO Left Main at that time. It was the last edition, I think. And we visited that and we saw some stuff we had never seen. And that was overwhelming to us. And we were captured like in the moment. And we thought, this is what we want to do. This will bring the field of cardiology, of interventional cardiology within the Netherlands. This will propel its kind of wings, and this will make it happen within the Netherlands. Yeah, that's how it started.
And you sure did. But how was the reception from the other people? Obviously, the department is there. It's a traditional department, large area, very prominent university. How was the reception of the program? Was it supportive? Did you run into difficulties?
Well, I think you will know the answer already. You're asking for the familiar answer. Of course, it was perceived like being the cowboys of interventional cardiology. The support was actually minimal. The surgeons did not understand because we were doing stuff with arteries that they not even could do. So even these days, our colleagues question sometimes the procedures that we do. So support, our boss was supportive. And I think if you want to start, you have to team up with your boss of the department. If he thinks it's something good, because you will face all kinds of complications, you are aware of yourself also, and that doesn't help starting. So we had a boss that was very supportive. He believed in the program. He said, we want to change things within the Netherlands. And of course, we're an academical side. So we also attached some research to that. And that helped also a lot to get the momentum. But yeah, the our fellow cardiologists, well, don't expect the support from them at first. Once you have proven yourself and you run a good program with a good result, then they become believers. But that's only afterwards.
Yeah, and I mean, you surely have taken the program to a different level, both in terms of the clinical outcomes, but also in terms of the research. You have one of the great research programs with a lot of work on physiology and imaging, a lot of things that have come out of that in the last several years. But as you said before, you have a lot of energy and passion. But how do you channel it when things don't go the way you were hoping for? You're doing it now; things are not going well. How do you deal with this unexpected challenges or complications or whatever doesn't go as
Yeah,
planned?
I think that's a matter of how you perceive the goals for the patients. Uh, what do you think is right to do? But also, it's part of character, I guess. There are some people that might be technical capable, but if you don't have the right, well, character to do this, because you will know you have to deal with deception and complications and, well, maybe even death. I hope you're not exposed to that as much, but you have to deal with that. So for me, it's like you want a good alternative treatment or a better treatment for some patients who cannot be treated anymore. You want to strive for a very good outcome that means a lot to you, and you have to have the character to do that. And sometimes we always make the joke, for every failed procedure, sorry, for every successful procedure, we had one beer afterwards. But for every failed procedure, we took two. So having three procedures on a day, well, at first we got drunk every day, but because of the beers that we had to take. But in the end, we successful and we only left with three beers. So it's and it's also the team and the energy between me and Paul that kind of wants us to propel each other to the next level. So it's those factors I think that come at play, and that you, well, for everybody else it might be different, but I think the main thing is character, ambitious, good result for the patient. I think those factors contribute a lot to such a program.
Yeah, exactly. And as you said, having someone next to you that you trust and that thinks similar to you can be a great way to go through the good and the bad days, as you just said. Now, how you said about the character and everything. Is it something that people either have it or they don't, or is it something that people can build over time and create it? Let's say if they're not to start
Yeah,
with.
I think it's partly you can create it. Of course, you have. Yeah, I think everybody who is willing to participate in the interventional world has something that is called like adrenaline. You need it, I think. but the extent of adrenaline that you need might differ between persons. And I think it is teachable. I think we have seen that, for instance, the hybrid algorithm that we adapted greatly in our department, you you will see that you can do in an algorithmic way, you can learn things and you can do things and you get familiar with it. So um, I think it is teachable to a certain extent. Uh, and you will know not at the beginning, once you start, whether you will be top level or not, but having like 100 under your belt, then you will know where you will end, I guess. Yeah.
Perfect. And then that brings us actually to the teaching. You obviously taught so many people, both at home but also in the various meetings around the world. How do you select the people you train in CTO? And are there some things that you look for that are kind of telling you this person is going to be a good operator or
No.
not?
Well, that's a very interesting question. We have both candidates from internally, but we also have a foreign or an exchange program with international interventionists. So the ones that are internal, you can actually see how they perform because they do a residency in interventional cardiology or a fellow in interventional cardiology. So you will be a kind of part of their journey becoming an interventionist. And then you also can predict whether or not he or she might be out of the same wood, like we say in the Netherlands, as you are. And well, it's not always the case that you think that somebody can do it and he can actually do it, and the other way around. So it's not like 100% score, of course, whether you can predict or not whether a person might be capable of doing these things. On the other hand, our international program, it's from hearsay. So our first fellow was Max Opolsky, and he came to us because he wanted to do some research on CT and CTOs. You might know Professor Opolsky now. He's back in Warsaw having his own program and his own meeting. So he was very well. Well, he did it himself, of course, but we were proud of having him in our lab, and that was by chance because we had never seen him operate. And in all honesty, at first, well, we had our thinking whether he would be able to do such stuff. But in the end, he was successful, and it was just by training, do cases, and some guidance of us. But so you cannot tell. Other came to us, and yes, that worked out a little bit less fortunate. In our mind, he's not that good that we hoped for. So of course you can kind of see whether a person might be able to, but not for the 100%.
And what's the most difficult thing to teach from all the things you do in CTO? What do you find the hardest thing? Is it the wire? Is it the thinking? Is it what is it that you find the hardest?
I think the hardest is to learn how to see things from a distance. While you're in the procedure, you get lost lots of times. We all know that. So it's more that you need to be aware of the steps that you perform and that you can critically view them from a distance, even when you're in the procedure. So take your rest, zoom out, and actually think the steps that you want to do or that you have to do. I think the way of thinking is the most difficult part to learn. I don't know if you have the same experience, but for me, it's not the hands, because you will see that some have the hands to do it. But we always say, and I think many others say, you do a CTO within your head, and the hands are just there to do it. But that's not how you solve CTOs. You do it in the head, and always think steps ahead. So those mental issues are more important to learn, and also very difficult to learn, I think, to other people.
Yeah, I know I could not agree with you more. Again, as you said, this is all starts in the head and then eventually gets translated. Of course, you do need to have some basic level of
Yeah.
dexterity with your hands-on coordination. But a big part of this is how you think about it and how you approach it, and not only for troubleshooting, but also for the for the next case and for the next case, and when things don't go well, and how do you approach it and you
Yeah,
synthesize it.
absolutely.
Now, when it comes to learning, any tips and tricks you can give people? Like, what do you think is one way to learn? Are there Should they take a guide and microcaster and start manipulating the wire? Should you look at pictures? What do you think is the best way to actually learn to do this
Well, I,
from
I,
the people who are
I
starting?
think the best way is actually putting them into the case. And then you might question whether you should be right next to the person or behind the glass. But I think they should get familiar with the atmosphere, with the pressure, with with kind of uh, well, the whole environment of doing a CTO. It's completely different as to regular PCI, because even the nurses and the staff around you, they always have a little bit of fear, and I think people should learn to be in an environment that might be, no, hostile is not the word that I would like to use, but it's people expect something of you. They are a bit afraid of what is going to happen. They don't know what's happening, and they accept or expect from you a different kind of handling and learning, and that's something that you should be exposed to as much as you can. So at first we always tell our fellows, just step in, take an MC and a wire, and we let them kind of fool around a little bit. And of course, we're there to step in when things are well, getting out of hand. But I think let them experience themselves how things feel. Doing the procedure is step one. Um, Step two is more like thinking ahead. What is the next step and why? So zoom out from the procedure that you're in, and tell me why you do things you do the way you do them. So that involves a little bit of self critique, criticism, acknowledgement, things that you know you're good at, that you're less good at. You have to be open in that. That's another thing that is very important, I think. And then, of course, how to handle stuff. So the materials and the wires, and to get the knowledge about the material they use and why you use this wire, that wire, etc. So I think those things are very important in how you teach people. And of course, if that's the way we like to do it, but it doesn't say that that's the way to do it. Others might have other experience by just taking them at hand and showing them how to do it and then do it themselves. Of course, that's other ideas. But for me, it's like put them in the pressure cooker, then learn to zoom out, and then think of the steps that you need to do, or what will be the next step, or anticipate on what can happen. And the third is like the dexterity and the handling of materials. Yeah,
Perfect. So nothing like actually doing what you're supposed to do. Nothing like doing what this is all about anyway. But you mentioned about the team. So do you do the cases with the same nurses and techs? Do you have a team that you work with? Are they changing every case? Did you teach them? How did that evolve in your
yeah.
program?
Well, luckily, and I don't. That will be different in other sites and programs. We actually had no program, so everybody needed to learn. So from the start, we had several nurses, and we asked, well, would you do like TAFI, or would you do like regular coronaries, or whatever, and who would like to do CTO? So those nurses that actually volunteered to do it with us, we had a common journey. So that means the whole team went into the program from scratch. So I don't know how that is in other hospitals, but we still have the same nurses like a decade ago who actually really like it. It's difficult to train other staff because they don't know, they have not had the same journey like we did together. So that's difficult for me to say or to anticipate on how you how you involve the staff. I think we just got lucky. But if you were to start a program, I would involve the nurses from scratch, directly involve them, make them feel important. They can learn about materials as we can. They can learn about algorithms as we can because we actually used to perform the cases together, Paul and me, from the start. But now we're alone or with a fellow and the nurse. So sometimes there is nobody next to me. And then the nurse says, well, you should switch, Alex. So it's actually really a team effort and everybody can learn this. So if you were to train the nurses, I would say grab them instantly and teach them and show them everything that you know and make yourself not more more important than they are. It's actually really a team effort, CTO PCI in my mind. So from scratch, nurses involve them massively.
Yeah, and I must admit that you guys are lucky. In the US, there's a lot of turnover right now in the cath lab. People are coming and going all the time, a lot of shortages. So unfortunately, you have to train them again. But couldn't agree more. It's like everything else. The more you do it, the better you get, and the more you can support. And I think you're right that the text can sometimes help us a lot because we do
Yeah,
get zoomed in too much, and then we lose the big picture of the case as well.
yeah,
So now, how about the radiation? Are you worried about radiation? You do so many cases and long cases, complex cases. How concerned are you about this, and what do you do to prevent any
yeah.
issues?
I think we could not stress this point more than you do like now to addressing this in this podcast because we actually started on a distance of 20. Now we use 25. Frame rate of 15. Now it's 7.5 or even 3.75 EP. Um, Also, of course, the lead around the patient and yourselves. And now you have these kind of devices from Rampart and Agnest, for instance, to get the radiation really down. Because we cannot see the radiation, we cannot feel it. It's just something that is hypothetically in our minds and we're not aware of it. But yes, having seen some colleagues getting ill, to see it like that, it addresses the topic more and more. And I think when you start it, always get those things straight. Um, Protect yourself. It's very important. Absolutely. So low frame rates, great distance, LED all over. Even try to, if you have a several amount of gray, to stage the procedure. For instance, if you do
Mhm.
multi-vessel disease with a CTO, stage it. Um, so of course the protection devices that are there, we use them. It's more like a general hygiene than that we think every case on the consequences of the radiation that we kind of are exposed to, simply because we don't have fear.
Wonderful. And are you using the Rampart or the ECNEST that you mentioned? Are you using them, or you're thinking of using them, or are you just using LED for
For
now?
now, we're using LED, and that's a pity because we did an application for both systems. Actually, I don't know whether the one is far better than the other. There is, I think, in both systems like a 90% reduction. So it's more like that we stressed our department and we stressed our bosses. Please, can you get this in for us because we are doing cases and cases and cases, and we are at risk here. Not for you, but for our own health. And you even wearing the lead, you might suffer like knee issues or hip issues or whatever back issues. You might even get out of the lab, and the losses are far greater. But it's budgetary problem. at least in the Netherlands and in our hospital, being an academic hospital, you can either spend 150K on other stuff or on a device for those interventionalists. They're always shouting, blah, blah, blah. So the board likes to use the money for different purposes than for our protection devices. Um, and well, that's a pity to see because yeah, it matters. It really matters.
Yeah, and I think you're right, and I think hopefully in the next few years we'll see a switch on that. I think people are there's more data coming out now, and at least in the US, it's a very litigious society. And if someone sues after he asks for a device and he's got, that's going to be a very big thing. So, but we don't want to get there. I mean, the whole point is that it's an important topic. There's shortage of money
Yeah,
everywhere. And the question is how much can you make it a priority? So hopefully, I think we'll see this evolve over the next time. So, Alex, again, you've done a phenomenal work on the program. Amazing amount of energy all the time. How can you find all this energy all the time, even with all these crazy cases that you are
yeah.
doing?
Well, again, I have to mirror you because you are doing so much stuff. We cannot even think of all the energy that you need to have to do all the stuff you do. We have it also, but it's because of we really like the coronaries. We're really into it. It's something that you cannot explain rational. It's just that you. It's sometimes we say it's not our work. We don't work. It's our hobby and our career. It's not work. We don't call it work. So it's difficult to say. Maybe other people perceive it differently, but the energy is well, you it's a journey every time. You don't know what you will see. You don't know what you will get. It's predictive, but it's also unpredictive, and it's the interplay between technical demands, technical devices, evolution of techniques. It's something new every time, and you cannot do otherwise than embrace it and love it, at least in my eyes. So um, it's the combination of all those facts and also with your own character, I guess. If you well are like an adrenaline junkie or yeah, it's difficult to say, I think. But
So obviously the passion is a big part
passion
of
is
this. You
really
obviously clearly enjoy what you do, but like, do you exercise? Do you get enough rest? I mean, how do you keep yourself in good shape to be able to do all
yeah.
these things?
Well, in the Netherlands, you might be aware of there's a lot of cycles, bicycles. So we also have at least well Paul also, but he's more like doing other stuff than cycling. But me, I have to cycle to my work every day 13 kilometers. So it's 25 a day. For me, that's sport. And yeah, so I do sport every day, and it's the combination. It's not only the physics, but also the mental issue. So when I step on my cycle, there's a psychological factor that comes into play, and that is you're outside. There is either rain or wind or sun. You feel it on your skin. Um, it makes me happy also doing those kinds of cycling tours and being able to work outside and get your hair or get your head empty. So it's the combination of like physical activity, getting your head clear out of issues from the lab while cycling. That keeps me kind of really enthusiastic and vibrant and energetic to do these kinds of cases.
I'm just curious. Do you also bike if you have a STEMI, or
Well,
do you
maybe it's
or
not
do
that
you?
good for the patient. So no, I don't like car.
All right, but I'm completely with you. I guess getting the exercise does seem to make a big difference. Do you do other things? Like, do you get how long do you sleep every night?
It's like 7 hours. Yeah, I go
Okay,
to bed like well, yeah, it's like 7 hours. Uh, well, yeah.
okay.
I think that's okay.
Perfect.
I would love to have more, but that's yeah, unfortunately not possible with our jobs. But yeah, I think it's very important. I agree with you that you should get some rest and take it every day, and don't rush yourself into do more stuff and shortcut yourself on sleep.
Sure. Now, how about any favorite book or movie that you have?
Ooh. Well, in all honesty, I don't read. Um, I don't read books and movies. I'm not into movies that either. So it's more like I enjoy having human contacts. Go to friends and family. I think that's really important. But no, I'm not into movies or reading. No,
Wow, that's I think you are the first
yeah,
person,
probably.
but this is great because that saves you so much
Yeah,
time, right? If you think
absolutely.
about it.
Yeah, well, once if I'm in bed, I may look to Netflix or whatever, but that's not really like that. I favor like movies or something. No, no, I don't have that point. No.
And then tell us a little bit. So obviously you do the clinical work, but also you've done a phenomenal work on the research side. You published many, many papers about the importance of the collaterals, the physiology, the imaging. How does that fit in the program, and how it has helped you and the team grow and
Yeah.
get better?
Well, actually, I have to say that that's completely Paul, because Paul did a PhD. I'm actually a pharmacologist and a pharmacist before I entered the field of cardiology, and Paul was there from the start doing research with PET. So he grew up in the imaging part, and then of course being an academical site, it's important to join forces and to get your program justified by doing research. And Paul is very good at kind of combining these things. And yeah, then we started the program, so we did it together. But he should be merited for that. So we directly saw the potential of doing research in these patients, having the opportunities that we have in our hospital, because we all aware that, and you even more than we, that most of interventionalists doing CTO, well, they're in it for the game, they're in it for the procedure, and not for the research as much as, well, I think should be done. So we saw that directly, and we have like the facilities of getting PhDs in and doing the research together with us. So they are there, involved from the start, and we include every patient, not in a randomly controlled trial, but in registries. So from the start, every patient is in there for the registry. And we had the luxury from the start to do all kinds of imaging techniques as well as physiology in these patients. So we combined PET, FFR, CT, whatever can be uh, can be can be kind of get from these patients to propel research. We could justify it just on clinical grounds, and that makes that we have a database of all these techniques combined together in a population of like, well, I think it's like, I don't know exactly, it's like 1,500, 200 are included right now. So we get the data from that. Yeah,
Yeah, congrats. And again, that's been a major effort, and I think that systematic approach really pays
yeah.
off. And again, thanks for actually putting the effort and the energy and getting this done. Now, from the many things, so you've done a lot of things, clinical research. What are the things that you're the most proud of, both personally and professionally?
Um, Personally, well, I think that the way you are as a person and you think about yourself is actually the most important and the goal of life, I think. Uh, when you die, you should be proud of yourself. So for me, I have several things that I'm really proud of during my life. And one is that we, or me personally, um, kind of conquered several personal issues that translated into work. Work made me think better of myself. that I could do stuff that I was really proud of, that others, well, might not be able to do, or they had less experience or training or whatever. But reaching this certain level of professionalism is very, yeah, I'm very proud of that as a person. Um, for the program, I think we changed how the interventionalists within the Netherlands, at least, think of how you should do PCI. It's not the way that you treat CTOs. It's more like how you should tackle every PCI procedure, having an alternative way of thinking. We want, for instance, when we started the program, a column came in, and we had some trouble engaging kind of the right, and we had a very aggressive guide, and they got a dissection into the right coronary ostium. And Column said, we said like, oh, what the fuck, we did not even start it. And Column said, now we have something to start. So it's the mind, change of mind, how you perceive things, which is important in my personal life. But also, I think, because we have been in every hospital within the Netherlands doing the CTO cases, changed the way the Netherlands interventionalists approach stuff. And I think that's, I'm proud of from a professional way. Yeah.
Yeah, and you really have done that not only in the Netherlands, but around the world as well with all the meetings that you've been to. So congratulations again. That's been an amazing amount of work on multiple levels. But going forward, what are the things right now that excite you the most, both in the CTO complex intervention and otherwise?
I think we're at a different level now. I mean, we have to justify what we do. I think we are getting exposed much and much more to kind of heart failure patients, post-CABG patients, and multifaceted disease patients, including CTOs. And I think it's shifting more from like coronary focus to heart failure focus combined with coronary artery disease, and how we should treat those patients. And you see it even in the meetings that there's a shift from antegrade, retrograde, blah blah blah, more towards the multifacetal patient with high risk PCI, and justification of mechanical circulatory support in those patients. So I think that's a shift we can make, or we have to make, as CTO community, but also as a community of cardiologists or regular cardiologists, that we have to find ways how we can best treat these patients, also justified with randomized controlled trials. So I think that's the direction that we should go, where our strength is, where we can actually have meaning for our patients in those directions. Yeah.
Wonderful. So, Alex, again, thanks for taking the time today. If you have to give the final word, what are the key things you would advise the people who are starting now or they're in early stages of learning to do this complex and CTO PCI? What would you advise them to do to get their skills as good as possible?
Go in there. Just go in. Don't think of all the setbacks. Don't think of all the things that might happen and might be not the best for the patient. Uh, it's more, you have to embrace it. You are, if you are able to do these things that we can and may do, it will make you a better interventionist. So just go for it, and consume as much materials and patience as you can to get the level of experience and of dexterity that you might get in the end. So go there with a different mindset. It's all about the mindset, I think, when you want to learn in this field.
Wonderful. So, thanks again. Thanks again, Alex. Congratulations again for all the things that you've done. Excellent tips and tricks for people to learn. and looking forward again to seeing you at the next meeting. Thank you so
Thank you,
much.
Manos. It's an honor to be invited to do this podcast. So thank you very much. And I'll see you in shortly.
Thank you for listening to the Sensei podcast.